ठीक है।
आ रहा है, ठीक है,
उनका आ रहा है, इसमें आएगा ना, ठीक है।
ये पीछे वाला लाइट आ रहा है,
बेस नहीं आ रहा साहब, मोबाइल में नहीं आएगा।
बस वही याद दिला रहे हैं, आ जाइएगा
स्विमिंग और ये CPR वगैरह बड़ा अच्छा होता है।
विकेट देते हुए लाया।
So good afternoon everybody. First of all, apology for starting little late, 15-20 minutes, being a Sunday. So most of our invited guests are on the way, but without delaying, let us start this proceeding. But before anything we start, as per our tradition, we start with prayer to the God. And today being very auspicious day, like starting as the Mahalaya, and particularly for the East Zone, Durga Puja is starting, that after 10 days we'll have. So I request Professor Vicky Agarwal, Professor H.K. Singh and Ved Prakash sir to join and light the lamp and grace this occasion.
ठीक है,
ठीक है सर।
या शुभ्रवस्त्रावृता या वीणाधरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती शुक्लां ब्रह्मविचारस आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्थाटतिं पद्मासने संस्थिताम् वन्दे तां परमेश्वरीं भगवतीं बुद्धि
Coming down on a Sunday, sparing your time. Can I have the next slide? Change. Okay. The agenda is there in front of you, everybody. So I think Dr. Agarwal doesn't need any introduction in front of each one of you. So Dr. Agarwal, please. So sir has more than almost 40 years of experience. One of the most senior, most GM gastro of the city as well as of the country. Very well known teacher. And there are many students. He has a lot of interest in liver disease particularly. And as far as I know, has done excellent work in hepatitis B elimination as well as eradication in this part of the country. So, Dr. Agarwal sir, please.
Professor H.K. Singh, Dr. Rohit Prakash, and many of my colleagues, Dr. Anil. So, I thank Dr. Mr. Mohanty for inviting me for this program. And it is a good initiative, I would say, that this metabolic disorders, practically I would say metabolic disorders are increasing leaps and bounds all over the world, but is now recently taken up more in India. And probably because of many things are because of genetic and I would say behavioral problem. Behavioral problem, the patient earlier, when you remember, patients after 20, 30 years ago, they used to ask, can I take milk, can I take ghee or butter, or now they are asking, can I take dry fruits, can I take this? It means the earning has increased, they have started spending money on their eating, and but this unbalanced and irregular. And that is the reason now we are seeing a large number of patients having many metabolic disorders. And I would say beyond 50 years of age, I think everybody will have something or other, either obesity or hypertension or diabetes or fatty liver or so many things. And now earlier we used to think that fatty liver is nothing specific, but now it has taken a great toll of people, their lives, liver disease. And I would say that if you talk something repeatedly on some topic, it means you have not yet found an ideal treatment for that. So we keep on talking and trying various type of therapies, but lifestyle modification, I would say, is one of the most important issues. Each and every problem, I would say, is very important, and people don't realize this. So now we have got so many good talks today, and very interesting talks. So I think I would slightly change the series. Your routine, because Dr. Ved Prakash has come, something like sing on the way. So we'll request Professor H.K. Singh. He has been head of the Department of Endocrinology at Patna Medical College, a very senior person, and with close friend of my elder brother, who also is an endocrinologist. So please kindly come on the dais. And the talk is Weight, the sixth vital sign, starting the conversation and taking a focused history, which is missing gradually nowadays with our new young doctors. So I would say you cannot overemphasize the history taking and taking full details of the patient's problem.
Respected Dr. Agarwal, and today's speaker is Dr. Ved Prakash. Obesity causing fatty liver diseases and the obesity again on cardiac problems, all the hypertension, atherosclerotic changes in the coronary artery.
Yes. Thank you, sir. Thank you, respected H.K. Singh, sir. Thank you, Professor B.K. Agarwal, sir. So, my topic is related to obesity and diabetes. So, as we all know that globally there is an epidemic of type 2 diabetes and obesity, and both are interlinked with each other. Like diabetes is not only a disease, basically it is a syndrome characterized by abnormalities of not only the carbohydrate metabolism but also protein metabolism and fat metabolism. And diabetes can affect almost all organ system of the body and in form of either microvascular complication or macrovascular complication or other non-vascular complications. similarly, obesity is one of the major risk factor for the development of the type 2 diabetes, and when both obesity and type 2 diabetes exist in a single individual, the term coined is diabesity. Diabesity means diabetes and obesity existing together. So both these conditions, diabetes, type 2 diabetes and obesity, are interlinked. What is the connecting link between these two diseases? I will discuss later on. So diabetes, before that discussing diabetes, there is a condition known as pre-diabetes. What is pre-diabetes? Pre-diabetes is basically the patient having glucose, the glucose tolerance between either there is between normal glucose tolerance and between diabetes, there is a stage known as pre-diabetes, and the incidence of pre-diabetes is very high worldwide, and currently the incidence is almost 1 in 3 individual is having pre-diabetes, and it is expected that by the year 2040 it is the incidence of pre-diabetes increases, and almost 60-70% of the persons globally will have either diabetes or pre-diabetes. So epidemiologically, diabetes is the 9th leading cause of the death worldwide, and the total number of estimated diabetic population worldwide currently is around 400 million. And by year 2040, the incidence and prevalence of type 2 diabetes will increase markedly, especially in the developing countries. In developed countries, the incidence of diabetes starts declining, whereas in developing countries and third world countries, the incidence of type 2 diabetes is on the increasing trend. And globally, overall, 40% of the global population has obesity. In slide, this is mentioned as diabetes, but that is wrong. It is basically related to the either 40% of the global population is having either they are overweight or having obesity. So these are the, actually in this slide we see the current scenario of these two prevalent non-communicable diseases, type 2 diabetes and obesity. India has currently 77 million of population having either overweight or diabetes. So overall, currently the incidence of pre-diabetes is around 7.3% globally, and India is also having the incidence of pre-diabetes is around 7%. It is 7.3%, and this is the prevalence of type 2 diabetes is also around 7% worldwide, and even in India it is around 7%. So the diabetes and obesity is not only a major health problem, but it is also an major economic problem to the global to the global economics. Out of $9 US dollar is spent on the healthcare, out of $9, $1 is spent on the diabetes only. So it is not a major public health problem, but it is also a major economic problem. And overall, if we see that 7.48 billion US dollar is spent on obesity, and around 760 billion US dollar is spent on the diabetes per year. So diabetes and obesity, where is the link? I will discuss in detail in later on. But a very good concept given by the Yajnik et al. And according to this, the thrifty genotype, and thrifty genotype is one of the proposed mechanism for this onset of the type 2 diabetes. And what is this proposed mechanism? According to this thrifty genotype-phenotype hypothesis, basically during the intrauterine period, critical time of intrauterine period, due to scarcity of the food, there are some epigenetic changes occur in the genome of the developing fetus that leads to the development of low birth weight baby at the low birth weight baby, and when there is surplus supply of the food, then it leads to the obesity and finally leads to the development of the type 2 diabetes. So diabetes and obesity, the link is basically there are three proposed hypotheses for this, how obesity is linked with the type 2 diabetes. And the first hypothesis is the inflammation hypothesis. As we all know that the type 2 diabetes is a chronic inflammatory disease, and also obesity is a chronic, low-grade chronic inflammatory disease. So what happens when a person develops obesity? It means that there is increased amount of adipose tissue throughout the body, and this adipose tissue, the circulatory macrophages migrated, and the circulatory macrophages who are migrated to the adipocytes is known as the adipocyte tissue macrophages, ATM. These tissue macrophages are basically of two types. One is the M1 and second is the M2. M1 subset of this tissue, adipose tissue macrophages are actually pro-inflammatory, whereas M2 subtypes is anti-inflammatory. So in obesity, there is upregulation of the M1 macrophages and there is downregulation of the M2 macrophages. So it means that there is an increase in the inflammatory state. See, so this increase in the inflammatory state leads to the production of the various cytokines like TNF alpha, interleukin 1, MCP1, and all these cytokines acts on the different organs like adipose tissue, like acts on the muscle, like acts on the pancreas and liver, and this leads to the changes which ultimately leads to the increased glucose production at the level of the liver, impaired beta cell function and beta cell regeneration at the level of the pancreas, and there is insulin resistance at the level of the muscle and insulin resistance at the level of the adipose tissue. So by this chronic inflammation, obesity basically causes insulin resistance and decreased beta cell function and beta cell regeneration. So these are the two major pathogenetic mechanisms for the etiopathogenesis of type 2 diabetes that leads to the onset of the type 2 diabetes. Another hypothesis is the lipid overflow hypothesis. What is this lipid overflow hypothesis? Lipid overflow hypothesis is basically when there is, in an obese person, there is excess of adipose tissue. So when normally where the adipocytes are present, that sites are, if saturated, then fat started deposited on the ectopic sites. Ectopic sites means like in the liver, like in the pancreas, and like in the muscles. So by this, this is also sometimes known as like fatty liver. It is also known as fatty pancreas and fatty muscles. So this deposition of fats in these three organs ultimately leads to the, at the level of liver, there is leads to the development of insulin resistance and increase in glucose production by increasing gluconeogenesis and decreasing glycogenolysis. At the level of muscle, there is by inhibiting AMP kinase pathway and other mechanisms, it causes decreased utilization of the glucose, peripheral glucose, and at the level of pancreas, it can cause insulin resistance and also beta cell secretory defect, leading to the decreased synthesis of insulin at the level of pancreas. The third mechanism, proposed mechanism, is the adipokine hypothesis. Adipokine hypothesis, as we all know that fat tissue is the largest endocrine organ of the body. So the adipocytes secretes various types of cytokines and various types of hormones which are known as adipokines. In these adipokines, the favorable or the beneficial adipokine is adiponectin, and the others are leptin, resistin, vaspin, retinol binding protein 4, and various interleukins like IL-1, IL-6, TNF alpha. So what happened due to obesity? There is in obesity there is decreased production of the favorable adipocytokines like adiponectin and increased production of unfavorable cytokines like various cytokines, and also there is leptin resistance. As we all know that leptin is an anorexic hormone, it causes decrease in appetite, but due to leptin resistance, the person's also starts, person's appetite increases, that also leads to the weight gain. So these are the three main hypotheses that are proposed to the connecting link between the obesity and type 2 diabetes. One is the adipocytokine hypothesis, lipid overflow hypothesis, and chronic inflammation. So diabetes and obesity. Obesity is basically not only related to the type 2 diabetes, it is associated with various conditions. Like in obese persons, there is increased incidence of hypertension, there is increased incidence of dyslipidemia, there is increased incidence of coronary artery disease, cerebrovascular disease, there is increased incidence of knee problems, there is multiple skeletal problems, and 11 types of cancers are associated with obesity. In mainly the cancers of the GI tract, like liver, hepatocellular carcinoma, CA pancreas, CAGB, colorectal carcinoma. All these are basically the incidence and prevalence is more in obese persons in comparison to the non-obese persons. So these are the basic slides. Diagnostic tests of diabetes. As we all know that there are three main diabetes can be diagnosed either by fasting plasma glucose or 2-hour postprandial plasma glucose or by HbA1c. If fasting plasma glucose is more than or equal to 126 and 2-hour plasma glucose is more than or equal to 200 and HbA1c is more than 6.5 or equal to 6.5, it is characterized as diabetes. What are the diagnostic tests for the obesity? For obesity, the simplest is the BMI. We calculate the BMI by knowing the person's weight and height. And if by BMI, I will discuss later, if with BMI, there are various patients can be characterized either as overweight or can be characterized as having mild obesity, moderate obesity and morbid obesity. So, diagnostic and classification of diabetes ADA by ADA 2022. Screening for type 1 diabetes should be done only in if there is family history of type 1 diabetes, and in that case screening can be done for type 1 diabetes. But in type 2 diabetes, if any person is having age more than 35 years and one of the additional risk factors like family history, sedentary lifestyle, like obesity, associated hypertension, like past history of impaired glucose tolerance, past history of GDM, past history of having baby birth weight more than 3.5 kg. So if any risk factor is present and patient's age is more than 35 years, patient should be screened for type 2 diabetes. And if on screening there is patient is not suffering from diabetes, then ideally the screening should be done every 3 years, but in high risk individuals it can be done annually also. So I have already discussed the diagnostic criteria of diabetes. The diagnostic criteria of obesity based on BMI. If BMI is more than 25 and less than 30, it is overweight. If it is BMI is more than 30 and less than 35, it is grade 1 obesity. Between 35 to 40, it is grade 2 obesity, and more than 40, it is morbid obesity or grade 3 obesity. But this is the worldwide accepted, but there is slight different criteria is there for the South Asian population. And in South Asian population, overweight is between 23 to 25. More than 23 and less than 25 is overweight, and between 25 to 30 is grade 1 obesity, 30 to 35 is grade 2 obesity, and 35, more than 35 is the morbid obesity. Because actually the Southeast Asian population is different from the European population or the Western population. And there is very beautiful phenotypic difference between the Western population and the Indian population. Like Indian population is characterized by overall less subcutaneous fat and more abdominal visceral fat. They have at least 1.5 times more insulin resistance, and they have lean body mass is less in comparison to the Western population, and fat mass is more. So all these are actually, so genetic composition of the Southeast Asian population is different from the Western population. That's why the diagnostic criteria of obesity is slightly different from the Western population. So pre-diabetes, the fasting between 100 to 125, PP between 140 to 199, and HbA1c between 5.7 to 6.4 is pre-diabetes. So management, management of type 2 diabetes is not only drugs. Management is basically, first is the lifestyle changes, intensive lifestyle changes in the form of diet control and exercise at least 150 minutes per week or 30 minutes per day. And besides these lifestyle changes, drugs and monitoring is very important for the management of type 2 diabetes. And the current concept of management of type 2 diabetes is not only sugar control, but the treatment of the other associated conditions like hypertension, like management of the obesity, like management of the dyslipidemia, like management of if any associated disease like cardiovascular disease or cerebrovascular disease. So overall, this type of management is known as the comprehensive diabetes management, which includes management of glycemia control plus management of the comorbidities. So treatment goal, HbA1c should be maintained less than 7%, but there are but if a population is in elderly population, this the HbA1c target can be somewhat, we actually want HbA1c between 7 to 7.5 or 7.5 to 8 depending on the patient's age and the comorbid condition. So it can be relaxed for in certain situations, but in adult population, ideally it should be maintained below 7. Fasting plasma glucose should be maintained between 90 to 130, and postprandial plasma glucose should be less than 180. So these are the targets. Besides glucose targets, blood pressure target in a diabetic patient is less. It should be ideally it should be maintained less than 130/80, but in elderly population or in elderly population more than 65 years of age, even 140 to 135/85 or 140/85 is sufficient. LDL ideally should be maintained less than 100 mg per deciliter, but in a non-CAD patients or non-cerebrovascular disease patients, the LDL target should be less than 70 mg per deciliter, or even cardiologists nowadays actually wants even lesser LDL than 70, even less than 50. HDL ideally should be more than 40, but there is no specific drug available in the Indian, actually available, but due to side effect, there is pharmacological options for increasing HDL is very limited. So HDL can be increased either by physical activity. So the best way to increase HDL is the physical activity. Triglyceride ideally should be maintained less than 150. In obesity, our goal is preventing further weight gain and reducing weight loss. By reducing weight loss, how much I target is should be 5 to 10% weight loss, and this 5 to 10% weight loss should be achieved in gradually, not sudden weight loss is a good thing. And ideally the weight loss should be 0.5 kg per week, and this for this 0.5 kg per week weight loss, we have to reduce, if we control by diet, then we have to reduce 500 kilocalorie per day dietary intake to reduce to obtain this much weight loss. So modalities of treatment, type 1 diabetes, it is we all know that insulin is the only treatment option. In type 2 diabetes, besides medical nutrition therapy and regular physical activity, either the various types of oral hypoglycemic agents are available, and also some parenteral drugs are available. So in lifestyle changes, ideally we should in dietary restriction, diet part of management of the obesity and type 2 diabetes, the ideal meal pattern should be which includes both carbohydrate, protein and fat in a balanced quantity, and at the same time avoid food with a high glycemic index, avoid fast foods and other food materials which are bad for the physical health, and at the same time for in exercise at least 30 minutes per day regular exercise or 150-minute regular exercise per week is mandatory. So pre-diabetes management, nothing. Only in pre-diabetes management, I will discuss later on one of the studies, that is diabetes prevention program. And this in DPP study, basically diabetes prevention program, pre-diabetic population is divided, has offered three treatment options. One is the intensive lifestyle change. Second is they have offered metformin, and in third arm they have given placebo. And in this DPP program, it has been found that the intensive lifestyle changes has the best effect in the prevention of onset of type 2 diabetes in a pre-diabetic population. And the magnitude of reduction of onset of type 2 diabetes in the tune of 60% by intensive lifestyle changes, and 35 in the tune of 35% in the metformin arm. So for the prevention of type 2 diabetes in a high risk population, intensive lifestyle changes is the best thing. And this DPP program follow up another study is the DPP OS timeline. In what is this? Actually in DPP OS, the population which are included in the DPP program is followed for another 10 years, and it has been found that even after 10 years of this intensive lifestyle changes, the incidence and prevalence of type 2 diabetes is less in that lifestyle change arm. And the incidence is even at the end of 10 years is reduced by 35%, and the onset of type 2 diabetes can be delayed by the 4 years. Whereas in metformin arm, the incidence of type 2 diabetes is reduced by 35%, and the onset of type 2 diabetes is delayed by 2 years in comparison to the placebo. So pharmacological interventions, there are various pharmacological options are available for the treatment of obesity, but most are actually not very effective. In the true sense, they are not very effective. For weight loss, the best way is to either by diet control and exercise. If we achieve weight loss, that is the best, because there are very limited options in terms of pharmacotherapy. The various drugs which are available is the phentermine, diethylpropion, orlistat, liraglutide, semaglutide, and one of the newer anti-diabetic drug, GLP-1 receptor agonist, semaglutide, is having the best effect on the weight. And semaglutide, in the various studies, it has been found that 0.3 milligram semaglutide per day can cause weight loss up to the 12%. Whereas with liraglutide, the weight loss is in the tune of 8%, and with the other drugs like orlistat, weight loss in the tune of 5 to 6%. So the only orlistat is available in our part of the world. Bupropion and this phentermine and this topiramate extended release preparations are not available. So we have in pharmacotherapy, we have one option, orlistat, and the other anti-diabetic drugs which can be used as anti-obesity drugs are the GLP-1 receptor agonist, and the offline use of this SGLT2 inhibitor can also be done, or it is basically used in the management of type 2 diabetes, but it is not approved yet. But GLP-1 receptor agonist is approved for the treatment of obesity also. So in summary, diabetes is a metabolic, vascular and neuropathic disorder. Diabesity is the modern epidemic indicating the coexistence of both diabetes and obesity, and pre-diabetes is a risk factor for progression to diabetes and cardiovascular disease. Lifestyle changes and weight reduction is superior to metformin in the management of pre-diabetes. So with this, I will end here.
Thank you. Thank you, Dr. Ved, for a very brilliant and informative lectures. all aspects. Present, this is a tremendous. Then I was not knowing 11 type of cancer
Yes.
linked with diabetes.
Linked with obesity, sir. Yes.
Then the dyslipidemia, micro and macrovascular complications of obesity, insulin resistance syndrome, metabolic syndrome, all you have covered, or treatment, management, and most important is the lifestyle change. If you change the lifestyle, you reduce the obesity, if 3 to 4 kg per month, then I continue the graph ascending, not the descending. So it will be very beneficial, and we can reduce
And south to north, that is it possible to categorize in one framework of whole population of India?
Sir, in the genetic, even genetic composition of the regarding in the northeast India is different from the people regarding in the. So, but it cannot be generalized. But overall, this is the Indian phenotype. It has been suggested. And
actually genetically Asia
all the aspects very well. It was a meticulous one. I had one doubt, one question about the role of microbiota in obesity, because recently there has been a lot of seminal works which has been done, which shows that gut microbiota has direct link to cardiovascular illness, psychological illness, including obesity. If I am not wrong, it is
also associated with type 2 diabetes.
King's College London, they presented a paper where they could show that there are
Gut microbiota is actually in the coming future, it is diabetes in the treatment of obesity and other related disorders.
and there is a role of set point theory
In obesity.
Because our body
Yes.
has an image of the brain where arcuate nucleus and hypothalamus. And they
I have not discussed that neurological part.
even if you try to cut down your calorie, you are not going to lose
Not
weight
going to
because
lose.
the
Set
metabolic
point
rate
is-
itself slows down. So with your less diet, you become a more fuel efficient engine.
Yeah.
And it is very difficult.
Very
So I think
difficult.
these two things are
So that's why the losing wherever मैं तो मरीजों को बोलता हूँ कि एवरेस्ट पर चढ़ाई चढ़ने के बराबर अपना वेट लूज करना है, क्योंकि उसमें वेट लूज करने के लिए एक्चुअली डिटर्मिनेशन चाहिए, साथ में पेशेंस चाहिए. These are the two most important things: determination and patience. If you do not have patience, then it is very difficult. एक महीना मरीज एक्सरसाइज करेगा, परहेज करेगा, बोलेगा आधा किलो वेट नहीं कम हुआ, हम करने से फायदा क्या होता है, छोड़ देगा. दूसरा ये है कि लोगों को अभी कोई बोल दिया तो उनको लगता है कि अभी वेट लूज करना है, लेकिन महीना 2 महीने के बाद जो इंथुजियाज्म था वो खत्म हो जाता है. इसलिए डिटर्मिनेशन की कमी है.
So childhood very tough and
Worldwide there is dramatic increase in the incidence of childhood obesity and childhood type 2 diabetes, and all these are related to the bad food habit. Thank you. Thank you.
So I request So now request Dr. Singh to felicitate Dr. Professor Agarwal. Now request Dr. S.K. Singh to felicitate
next talk is cases in BP and lipids. Dr. N.P. Verma, and I requested Professor Verma to chair the session.
Post coordinator B.K. Agarwal delegates and friends, we have wonderful session. We just heard about obesity. The second case is blood pressure and lipid. I think most relevant topic we hear at any conference, and to deliver the lecture we have no other than our teacher, again a senior most physician. We have seen sir working in ICU. Actually, I have admired his work so much, Dr. N.P. Verma sir. So without wasting any time, I'll request sir to start the deliberation.
To you. And there is no doubt that he is a brilliant diabetologist, fantastic human being. Thank you very much, Dr. Subhash, and respected Dr. H.K. Singh sir and Dr. B.K. Agarwal sir and friends. Metabolic syndrome. So it should be listened in that context. So this is blood pressure and lipids, and these are the topics which I am going to cover before you. And high BP is a common component of metabolic obesity, insulin resistance, hypertension, dyslipidemia, microalbuminuria. And you will be surprised to know that in Pamela study, in metabolic syndrome, about 80% of the patients were hypertensive. And if metabolic syndrome is when the patient is hypertensive, and if the metabolic syndrome is also associated with that patient, the chances of developing cardiovascular disease is enhanced. So with this background, what we will see that the second thing is hyperlipidemia, and the typical hyperlipidemic hallmark is triglyceride level is high, low HDL, normal or little raised LDL. I am not sure, my cardiologist friend will say that whether the triglyceride is an independent risk factor for cardiovascular disease or not, but one thing it does definitely, and that is that it lowers the HDL level and it stiffens the artery. So that way it is going to promote, or it is going to contribute in atherosclerotic disorder. And once the hypertension and dyslipidemia is present in single patient, the chances of cardiovascular disease is enhanced, and it is enhanced more than in its additive form. So if suppose 5% is enhanced by the dyslipidemia, 5% by the hypertension, and if you have these two factors are in the same patient, it is not 10%, it is more than 10%. So that you can see how deadly this combination is in a patient. So let us have some incidence and prevalence, and if we see the Indian scenario, about every third is a hypertensive patient, and unfortunately only 10 to 15% of the population is under control. Not a very good scenario globally also, because there is also only 20% people are being controlled. And now see the Indian scenario about cholesterol. It is urban, definitely it is more, about 25 to 30%, and in rural it is 15 to 20%. But this 15 to 20% in today's scenario is too much. Still a large population of India is living in rural area, and if you convert it in absolute number, it is going to be a huge burden on Indian healthcare system. So this 15 to 20% is a big number for us, and this prevalence can be ranged from 1:125 to 1:450. And this is the word leaky tension. This leaky tension has been introduced when hypertension and lipid disorder is present in the same patient, and how they are affecting each other. some data is that 40% of the new hypertensive have at least one lipid abnormality. And once it is there, the risk of cardiovascular disease, I told you before, is enhanced. There was one trial known as ASCOT trial. That ASCOT trial was actually the BP lowering trial. And in that about 19,000 patients were recruited, and out of these 19,000, 10,000 patients were selected and they were divided in two groups, and along with the antihypertensive group they were given atorvastatin in one arm and the other arm was only taking atorvastatin. And they found that there was a significant improvement. There was about 30 to 34% relative risk reduction in the cardiovascular diseases who were receiving atorvastatin. Not only that, when the trial was prematurely stopped because of its beneficial effect, there was a carryover effect of the atorvastatin. Even after intermingling of these two groups, the benefit of atorvastatin was carried over. So this justifies the use of a statin properly in the patients who were having hypertension with the lipid disorder, and in those populations the baseline cholesterol level was less than 6.5 millimoles. If you want to convert it in milligram, you can multiply it by 38.6 or 40, that will give you in milligram the number. These two studies, that is one is BCAP and ELVA, are very, very important studies, because beta cap cholesterol lowering asymptomatic plus study showed for the first time in human being that with the use of betoprolol extended release tablets, there is reduction of intima medial thickness, carotid intima medial thickness, and that was significant. That was the first evidence. And the ELVA study showed that the reduction in plaque size was independent, or was the action was different from the atorvastatin. So these two important trials reinforce that use of beta blocker as an antihypertensive in a patient, in a hypertensive patient who is dyslipidemic also, is going to benefit not in his blood pressure but also is going to benefit in lipid profile. Diagnosis, we all know that hypertensive patients have very few symptoms, headache, palpitation, shortness of breath. So it is always that when you measure, you know that this patient is hypertensive. And once you diagnose that he is hypertensive, you are supposed to screen for his KFT, his ECG, his echo, and all these things you do because this helps you to know whether the patient is having any other comorbidity or not, and that will help you in selecting the antihypertensive drug. That will one thing, and the other thing that you will also see that because of this hypertension, if any end organ damage is being started or not, or is being damaged or not. So this is the way how you measure a blood pressure. The patient has to be relaxed for 3 to 5 minutes in a sitting posture with the foot on the ground, and the cup size should be adequate, at least covering from the more than 70% to the 100% of the arm, and he should not have taken alcohol, caffeine or smoking for 30 minutes. If you are using automated electronic device, then you should follow the instruction of the company that how much area of the arm should be covered. And one thing is very important, that the arm should be naked, not over the shirt or over the pullover. So that is the way how you take. And one more thing is also very important, that when you are taking the blood pressure, the one reading you do not diagnose the patient to be hypertensive. And if you come to lipid disorder, again it is the screening that will give you the idea that whether this patient is suffering from lipid disorder or not. And if the patient is having established cardiovascular disease, it is prudent to do lipoprotein A and apolipoprotein B and A1 ratio. That gives you a better idea of future coronary events. So now the management part. We all know that for any disease, whether it is fever or it is diabetes or it is hypertension or it is coronary artery disease, whatever disease you have read in your textbook, the lifestyle management is very important. So the non-pharmacological is the lifestyle modification, and what modification we will see in next slide. And after that, when your lifestyle modification fails, you start taking drugs. And this is the DASH, which all know that is the dietary approach to the stop hypertension. I am not going to elaborate everything, but the three important things in here are: you take fruits and vegetables, minimize your carbohydrate and minimize your salt, try to maintain your weight, about which Dr. Ved was giving an extensive lecture, and Subhash was pinpointing the reasons why we do not lose weight even after dietary restriction. But then you have to do it whether this way or that way. Saturated fat is out. Sodium. So we all know this mean arterial pressure is reduced very little in a normal patient if you are taking less sodium. But if you are hypertensive, the reduction is significant. And the mean arterial pressure is what? It is a systolic plus 2 into diastolic by 3. And that is that usually the normal level should be between 70 to 100. So you should try to maintain it between that, not beyond that, not less than that. Regular physical exercise, and that is important, aerobic. Apart from all your pranayam and yoga, this aerobic exercise is very important, and that includes walking, running, swimming and cycling. So some sort of aerobic exercise you are supposed to do daily. And then the pharmacological treatments are the three main cardinal drugs. One is the thiazide diuretics, ACE and R inhibitors, calcium channel blockers. And when the combination drug is recommended, it is recommended when the systolic is above 20 and diastolic is above 10 from the target, higher than the target. And it is also advised, it is an international recommendation that the combination drug should be taken in single pill. And this is how you manage your lipid. So once the first thing is the modification of lifestyle, but this is a very exhaustive and very difficult criteria that how much lipid should be lower. For all practical purposes, if you are not having established cardiovascular disease and if you are not having multiple cardiovascular risk factors, anything less than 100 is of LDL is okay. But if you are having cardiovascular disease and if you are having multiple cardiovascular risk factors, your LDL should be less than 70, and for that you should try either the high intensity statin or the dose of the statin which is going to be tolerated by you. And if it is not controlled by the statin, you may add ezetimibe and then PCSK9 inhibitors. So for the basic, the thing is for patients who are not at a very high risk, make his LDL less than 100. Patients who are at a very, very high risk or who has a heart disease or who has established cardiovascular disease or has comorbidities like diabetes, chronic kidney disease, hypertension, make his LDL less than 70. One more thing is there, when we treat lipid disorder, we target LDL. But our desire is also to see that the triglycerides should also come down. This is a desire, not the target. So our treatment should focus on LDL with the approach that triglycerides should also come down. And these are some nutraceuticals. I don't know how they help. Berries, coenzyme Q, green tea. They are saying that there are some evidence, but it is open to the House to accept it or reject it. My personal experience is very poor about it. And now here are some important things about beta blockers. Anti-hyper drugs with effect on serum lipids, and you will find, and we all have been taught that when we use the older beta blockers, the triglyceride level goes up and the high HDL comes down. So that is a catch. A patient is a diabetic or a patient is a hypertensive or disorder, he is having a lipid disorder order, and there is a compelling indication to use beta blocker. Will you use beta blocker or not? That is a very, very important thing. But for your information, with the advancement of the newer beta blockers like pindolol or carvedilol or acylbutolol, so these beta blockers who are having internal sympathomimetic actions, they have a favorable effect on lipid disorder, unlike metoprolol, propranolol, and other beta sotalol, which lowers the triglyceride. These beta blockers does not have any effect on LDL, and these propranolol or etalol, which increases the triglyceride, this increment is insignificant. So if there is an indication, compelling indication of beta blocker, just for the lipid disorder, you cannot deny that treatment to that patient. That should be very, very clear to you in your mind. And the lifestyle modification has been found to reduce the blood pressure about 4 to 9 millimeter mercury. That is quite significant. And these are the drugs: thiazide diuretic, ACE inhibitor, ARBs, and calcium channel blocker as the first line, which we have seen earlier.